Chapter 10. We'll be discussing the overview of nutrition diagnosis and intervention. So this should be a bit of a review with some new information thrown in. So our objectives, we'll define the role of the dietitian within the healthcare system, we'll review the steps of the nutrition care process, and we'll describe the general procedures involved in each step of the nutrition care process, including possible methods for assessment, intervention, and medical documentation. So taking a look at clinical nutrition, and so again what we're going to actually be doing is providing medical nutrition therapy. And so clinical dietitians are the educated and trained professionals who can best deliver nutrition therapy using, again, the standardized process known as the nutrition care process. So looking at the role of the dietitian in healthcare, so again, since you're actually having to live this, you're probably pretty familiar with this, but to become a educated and trained member of the healthcare team, again, you have the didactic portion of the dietetics program, which is what you're in currently, which is the coursework. And then there's the internship or supervised practice, where again, we're going to apply your training in the clinical setting. Now again, we'll talk about critical thinking because that's the biggest thing with medical nutrition therapy is actually being able to analyze the situation. And so again, right after you take the RD exam, you can become RD, or if you want to use the initials, RDN. But you do have continuing education, so again, you're learning information as it is currently known, realizing that it will change, and so over the next 5-year period, you are responsible, for continuing your education and seeking out new learning opportunities. So where do clinical dietitians work? So they can work in the acute care or hospital setting. They may work in a long-term care setting, such as a skilled nursing facility or an assisted living facility. You can work in outpatient counseling. You can work in dialysis, and so I know we're not on campus right now, but I'm sure you all remember the Just Move just down the street, down Griffin Road. You'll notice that next door to it there is a dialysis center, so all dialysis centers have dietitians, or at least they share one so they have access to one. Dietitians can also work with home healthcare or an infusion company, so looking at how pumps are set up in the home, looking at those durable medical equipment, how it's leased or rented, looking at how supplies can be delivered to the patient's home. They can also work in hospice or as consultants. So here we have a table. So here's the responsibilities and tasks of clinical nutrition team members. And so one of the frustrating things, so depending on how you feel about it, is that dietitians have very limited upward mobility. So dietitians have a lot of lateral mobility, so they can change positions and do a lot of different things. But typically in the hospital, there's really only 2 jobs, especially when you're looking at a clinical dietitian work. Now, again, you can do food service, etc. But if you're looking at clinical work, you have the clinical dietitian, which is you, and then you have the clinical nutrition manager, which is your boss. And that's it. Now, again, like I said, you can go into different tracks, you can go into hospital management, etc., but that's not really being a dietitian at that point. So you have the clinical nutrition manager, so that's the person who's in charge of managing, which is directing the activities of the clinical dietitians, the diet techs, and the dietary assistants. Again, this is all the hiring, firing, training, productivity reports, etc. You have the actual clinical dietitian who actually is providing direct nutrition care for patients. This is your assessments, this is your developing your interventions, your diagnoses, your nutrition care plans. There is the diet tech position, although it's kind of being phased out. So 1, through educational requirements, and then 2, a lot of states and CMS have actually restricted what diet techs are allowed to do, in which case it's no longer cost effective to hire them. But in essence, they used to see that lower risk patient, but they can assist with gathering information for screening. And then they kind of can do that halfway between what a dietitian and then your diet clerk or diet assistant can do, which again, this is your direct contact with patients, looking at taking orders, building trays, record keeping, etc. So looking at the roles of the RD in healthcare, so again, there's different board certifications depending on once you've been in dietetics long enough and you've decided what you want to specialize in. So again, the board certifications take 2 years, and then each of these other specialty certifications has their own requirements. So we do have the board certified specialist in pediatric nutrition, renal nutrition, gerontological nutrition, sports dietetics, and oncology nutrition. Now there's also the CDE, which is now actually, I think, just changed, which is your Certified Diabetes Educator, although there's a new initials for it, but it's the same role of being a specialist. You also have the Certified Nutrition Support Dietitian or Certified Nutrition Support Clinician. And again, this is through Aspen, so if you want to be an expert in looking at nutrition support, so this is your tube feeds, TPNs, etc. And dietitians are eligible if you want to become a lactation consultant. You are eligible for the IBCLC. There's just some additional training paperwork that you have to make sure you've completed. So looking at the healthcare team, so the biggest thing is that dietitians are very big in working in the interdisciplinary field, which is going between all of these different healthcare providers, because we have to, in essence, know enough about what each person is doing, because at the end of the day, everything affects nutrition. So you have the medical doctor, which can be an MD, a DO, or the PA, whoever's their direct representative. So again, you're looking at the medical diagnoses, the condition, the treatment plan. You have the nurse, which again can be anything from CNA, LPN, RNs, ARMPs. So again, looking at implementing those care plans. You have the pharmacist, so looking at medication management. Occupational therapy, and so occupational therapy is doing things versus physical therapy, right, which is looking at strength and conditioning, which is, are you actually in the physical condition to get out of bed, versus occupational therapy is, do you have the coordination to brush your hair, brush your teeth, prepare food, etc. Speech language pathologist, so looking at swallowing, safety, and speech. Social worker and case manager, so again looking at handling discharge, so what's going to happen to the patient after they're discharged, and then of course you have us. And so again, if you can imagine though, a patient's medical condition affects what diet they get. The nurse is going to control what diet gets delivered to them, how things are executed on the floor. The medications prescribed by the pharmacist are going to affect appetite, tolerance. Occupational therapy, can the patient actually cut up their own food or do they need assistance? Speech language pathologist, can the patient swallow safely the food you're ordering for them? Physical therapy, are they even strong enough, right, to handle the rest of their daily needs? For example, preparing meals, standing in front of a stove, etc. And who's going to help them when they go home? Your social worker and case management. So we have to know enough about each other person's job to make sure that if we have a specific diagnosis and intervention, that we're actually going and talking to the right person to get it done. So again, this medical nutrition therapy is nutritional and diagnostic therapy and counseling services for the purposes of disease management, which are furnished by a registered dietitian or nutrition professional. So looking at healthcare services and reimbursement for MNT, so looking at insurance, so the 2018 statistics from the Census Bureau, so 8.5% of the population had no health insurance at any given point in time. And then looking at where we do get insurance from, so 67.3% of the U.S. population is covered by private health insurance, which is through employers. And then looking at public insurance options, so we have Medicare and Medicaid. So 17.6% of the U.S. population is covered by Medicare Part B. And so specifically when I say we're referring to Part B, that's for how dietitians are reimbursed. So this is for diabetes, non-dialysis renal disease, and renal transplant. There's other coverage, but not for dietitians. And 17.9% of the U.S. population is covered by Medicaid. And so again, remember that this is federal money, but its implementation is based on the state and how they choose to implement it. And so coverage is based on diagnosis, not length of stay. And so you'll hear this, and we'll talk about this theme throughout the lectures. But in essence, right, the big criticism with healthcare currently, for example, is, and I'm just making up a number, but if you have a heart attack, then depending on the type of heart attack, because there's different ICD-10 codes for that, but depending on the type of heart attack, then you will be in the hospital for, quote-unquote, 5 days. Now, if the hospital fixes you sooner because they did their job perfectly, and you get out in 4 days, the hospital gets to keep that 5th day's worth of money. On the flip side, if the hospital does a bad job and you're in the hospital for 6 or 7 days, the government only pays for the first 5 days, and the 6th and 7th day come out of the hospital's pocket. And so what happens is you kind of have this tension where we're trying to not go under because we're losing money and still providing quality care. So again, you have this tension where it creates some aggravation in the hospital. Now looking at critical thinking, because the biggest thing is that you have to be able to critically think and combine, like I said, you have to understand your job as well as everyone else's job and look at the big picture to be able to determine what's most important for taking care of this patient. So critical thinking, so we have from a Delphi consensus group, so purposeful self-regulatory judgment, which results in interpretation, analysis, evaluation, and inferences, as well as explanation of the evidential, conceptual, methodological, criteriological, or contextual considerations upon which that judgment is based. So in essence, when it comes down to treatment, you have to decide what's most important and what's going to kill him first. And you're going to make that determination using critical thinking. So our components of critical thinking, so we have our specific knowledge base, experience, competencies, attitudes, and standards. So looking at specific knowledge base, so again, the knowledge of nutrition and its role in health and disease. So there are minimum standards of education, so this comes from Ascend and from the Academy. So again, this is the bare minimum that you're required to be taught. Now, of course, we go above and beyond that, but there is a bare minimum standard of what you're expected to know from the didactic portion when you graduate. And so again, continually changing, expanding knowledge and skills. So even after you have the bare minimum knowledge from your program, right, we need to do continuing education. Again, things do change, technology changes, new tube feeding techniques, etc. So looking at experience, and so here you have your supervised practice or your internship. So you're looking at real patients with real problems. And so again, you're going to be observing and listening to patients, interacting with other healthcare professionals, and reflecting on situations that arise. So you do get to keep a lovely journal to kind of keep your thoughts in order, what you've learned, kind of how you would approach things. Would you approach things differently? And again, through continued application and practice as a professional, which again, you'll get feedback from your clinical nutrition manager, from your regional manager, etc. Again, you'll be evaluated for how you're progressing, how your skills and your treatment plans are going. So competencies, so cognitive processes to make clinical judgments. Again, your ability to identify problems and make decisions using the scientific method and evaluating critically reviewed research. Looking at your evidence-based dietetics practice, which again we'll talk about. So this is going to be through the evidence analysis library. Again, using what we actually know works, not just going on a whim. Problem solving, decision making, and diagnostic reasoning. So again, how do we arrive at our decisions? Also a combination of our attitudes, which is a reflection of our values, so considering fairness and responsibility. So like I said, there's this tension of what's best for your patient versus what you can actually get implemented. And then standards, so there are professional standards, and we do have a code of ethics. And so again, the dietetics practitioner practices dietetics based on scientific principles and current information. So again, if you want to go off script and go all willy-nilly, right, that can be grounds for losing, right, your registration, because again, the idea is that we are doing things based on science and evidence, and there is outcomes research, which is if we did this, the patient got better. When we did that, the patient did not get better. Well, then don't do that, right, going forward. Now looking at levels of clinical reasoning, so again, we don't expect you to master this overnight, so we do have entry-level practice. So this is very basic, low level, right, critical thinking, relying on facts and principles, which is, I see this in the book, I see this in my patient, this is what I do, and that's exactly where you should be. But as you gain experience and exposure, right, with more experience comes the ability to examine alternatives independently, systematically, disconnecting from authority, and the ability to anticipate outcomes, which is, well, okay, they have this and this, but because of this situation, I'm going to do it this way, and we should get this result. And at the highest level, we're able to analyze the entire situation, we're held accountable for our decisions, and continuous quality of care assessment. So again, this is that ongoing monitoring, which is, well, I've been noticing in this particular type of patient, when we do this, we get a better outcome. So we look at the data, we see how many patients we've treated, what's happened, your clinical nutrition manager keeps a record, and we go, you know what, that's a good idea. Here, we're going to start doing it this way. So looking at the nutrition care process, so of course, these techniques and this process has always been there, but what we did is we standardized it. So this was done by when we were still the ADA in 2003. And so we standardized this method for providing nutrition care to improve the quality of care and positive outcomes. And so the definition is technically a systematic problem-solving method that dietetics practitioners use to critically think and make decisions to address nutrition-related problems and provide safe, effective, high-quality nutrition care. Now we do use standardized language, and so again, you'll get more familiar with this through the ENCPT, right? You've had that training, and now you're going to look at the NCPT manual. So this is uniform technology to describe practice with standardized phrases or terms so we're all on the same page, and provides a common language for documentation and communication. So we'll talk more about how dietitians don't follow patients, they follow floors. So looking at standardized process, so again, we have a consistent structure and framework used to provide nutrition care, but this is not standardized care. So what we're not saying is if you have a heart attack, you get this diet, you get these meds, you get this education sheet, right? That's standardized care, and that's obviously not effective. What it is, though, is what we say is that, all right, if you come in, I do a screening. Based on the screening, I do an assessment. In my assessment, I will look for anthropological, biochemical, clinical status, right, social economic history, etc. So I have the same process that I follow, but you don't treat everyone the same. That would obviously not be effective. So here you can see this is the nutrition care process and model, and so we can see how we have our diagnosis, our intervention, our monitoring and evaluation, and again, this is followed up with a reassessment. So if you see a patient a second time in the hospital, is what you're doing working? Do we need to make changes? Do we need to continue on, etc., etc.? So looking at the nutrition care process, so again, these 4 steps make up the ADIME. So we have our assessment, diagnosis, intervention, and then monitoring and evaluation is really all kind of together. So diving a little bit more into the nutrition care process, we're going to first take a look at screening and assessment. And so screening provides a mechanism for us to identify patients or clients that would benefit from the assessment, i.e., in most facilities, dietitians do not see every single patient in the hospital. Now, in long-term care or in some smaller acute care facilities, sometimes that is the case where the dietitian will see every patient. But most of the time, we have to see who really needs our attention with our current patient to dietitian ratios. Now, screening is often incorporated into the admission assessment, so they'll ask you questions when you first get to the hospital. What brings you in? How long has this been going on? Have you been losing any weight? Have you been vomiting, right? And then if they've been vomiting for a certain number of days, we get a call. If they've been losing weight, we get a call, etc. So patients are identified as being at risk and then referred to the RD for a completed assessment. So we have to go in and do a full assessment with them. And rescreening should be done at regular intervals during admission. So again, if anything goes wrong during admission, nursing or another healthcare team member keeps us informed so we can continue to check on these patients. Now we're going to talk about the 5 domains of nutrition assessment, i.e. these are the big categories for everything we look at when assessing a patient. So we have food and nutrition related history, anthropometric measurements, this is all the standard height, weight, BMI, etc. Your biochemical, medical tests and procedures, so this is going to be your labs, procedure results, right? So if we looked inside the GI tract, right, with our endoscopies, etc. Physical findings, which we'll do more in person when we're on campus, and again, of course, and obviously a client history of so what's been going wrong. Now again, we have our diagnosis, so this is the second portion for the A, and then the diagnosis for the ADIME. So this is a diagnosis that's made after an assessment of nutrition status using all available data. Again, you're going to use that critical judgment and the critical thinking skills as part of your decision-making process. You're going to include a simple, clear, and documented PES statement, and we're going to be talking about that throughout the course. So the most important and urgent problem should be selected for a PES statement, and again, prioritize diagnostic statements with the client or family if possible. So again, especially if you're having to work on this, right, you need people helping you, supporting you, right, to get the outcomes that you want. But in essence, the way you think of the PES statement is what's going to kill them first. Because you will have many patients with multiple diagnoses, but you do write them in an order of importance. So again, I can't tell you the number of times I've had students will do this, which is a patient is in the ICU on a breathing machine, just had a heart attack. And I get the diagnosis, nutrition-related knowledge deficit. They need to be taught about a heart-healthy diet. Well, that's true, only if they survive and get out of the ICU. So again, we have to have priorities in order, right? So they'll need diet education eventually. But first, we've got to worry about their intake and their tube feeding and surviving the ICU. And then we can educate them. And then for that PES statement, again, we've got our 3 steps. So we're going to identify the problem, stating it clearly and singularly, so one problem at a time. We don't try and combine them into like a super problem. Focusing on those that can be treated by a nutrition intervention. So again, we can look at a patient's lab report. I know it, you know it. It's clearly hypothyroidism, but that's an endocrinologist determination, not something that we can diagnose and treat. You're going to explore the etiology or the cause or the why it's happening, focusing on nutrition-related causes, not medical diagnoses again, and again then describing the signs and symptoms. So there's a big emphasis on formatting, which is so as long as you follow the format, there's no right or wrong PES statements, but again, some are better than others. So again, we talked about, for example, that heart disease and that diet education. Well, that's correctly written, but not at the right time. So an example, our problem, involuntary weight loss. That's what's wrong. Why? Why is he losing weight? Because he has poor appetite. Now, what's your evidence, or how do you know? Or prove it to me. He's lost weight 8% in 1 month. So your diagnosis was he lost weight. Your signs and symptoms better be weight loss, otherwise they don't really connect. Now there are 3 domains of nutrition diagnosis, or 3 umbrella areas where things can go wrong, which is intake, too much or too little of a food or nutrient compared to the actual or estimated needs. Clinical domain, so this is related to medical or physical conditions, and behavioral environmental, which is things like knowledge, attitudes, beliefs, physical environment, access to food, or food safety. Now looking at nutrition intervention, so again our next step of how do we fix things. So these are actions taken intended to address the nutrition problem. This is our planning and implementation steps to make a change. Now again, these are patient-centered goals, and we'll do more with goal setting throughout the program, but specifically in counseling, we'll talk a lot more about goal setting. Interventions should be specific. What, where, when, how. Again, lose weight. Not helpful. How much weight is this patient going to lose? How quickly? How are we going to check on it, etc., etc. And again, we do have evidence-based nutrition practice guidelines. So there actually are guidelines online, and I can show you all how to use the EAL. If you're sitting there going, well, I know absolutely nothing about this condition, where do I start? So again, our interventions are purposefully planned actions designed with the intent of changing a nutrition-related behavior, risk factor, environmental condition, or aspect of health status for an individual, target group, or community at large. And again, the biggest thing here is you need client buy-in. And in a perfect world, right, it'd be a client set goal, right? Their intervention is something that they're going to say, here's my goal. I'm willing to do these things to achieve it, right? As long as you kind of give them a menu of options. Now we have 4 categories of interventions, and we can talk more about this, especially as we start looking through that NCPT book. So food or nutrient delivery, so individualized approach for food and nutrition provision. So how do we get the nutrition in their body? Education, to train or instruct the patient or client in a skill or imparting knowledge. Counseling, which is looking at goals and behavior changes. And then coordination of nutrition care with things like consults, referrals, so other agencies, institutions, caseworkers, etc. And then lastly, we have our monitor and evaluate. So you've diagnosed a problem. Well, how do you know if you actually fixed it? So here we want to determine the amount of progress that's made and whether goals are being met. We want to pick specific indicators that should be monitored. Again, these should match the signs and symptoms from the PES statement. If you said the patient was losing weight, you better check on their weight. If you said the patient had poor blood glucose control, you better check on their blood glucose, right? So we say their patient's losing weight, and then we want to check their labs. Not a good monitoring. And again, we also need to determine how frequently we should monitor these patients. So again, our evidence-based guidelines. So evidence-based practice is the use of the current best evidence to make decisions about the care of patients or clients. Now again, best evidence comes from a combination of high-quality research, systematic reviews of the literature, and meta-analyses to support decisions made in practice. And again, using these evidence-based guidelines leads to improved quality of care, which is we do things that work because we know they work, because we've proved it with science. Now you do have the EAL. So again, you should be a member of AND. It is required by the program, and this is how you gain access to the evidence-based nutrition practice guidelines, which are available through the EAL. And we can discuss this and show you how to use this during Zoom. But this is on Eat Right's website, specifically Eat Right Pro, once you log in. So the Academy of Nutrition and Dietetics, again, we have our scope of dietetics practice and framework. So that's, again, how we're supposed to go about our jobs. And we also have standards of professional performance. So we have standards of practice and performance. And these are tools for credentialed dietetics practitioners to use in their professional development. These serve as guides for self-evaluation and to determine the education and skills needed to advance an individual's level of practice. Although not regulations, the standards may be used by regulatory agencies to determine competency for credentialed dietetics practitioners. And that's what most states do, right? So especially states that have licensures, they're really just based off of the academies and the registration's recommendations, and they just kind of have adopted them. So we do have a code of ethics. It's pretty common sense, but just in case you're curious. And so the Academy and CDR believe is in the best interest of the profession and the public it serves to have a code of ethics in place that provides guidance to dietetics practitioners in their professional practice and conduct. The biggest thing, right, is that you just can't knowingly lie to people to sell them things. And it's those kinds of things, right, where you're kind of held to a higher standard because you have more knowledge. You're expected to be more ethical, and again, practicing with the patient's best interest. Now looking at accreditation and surveys. So we have the Joint Commission, formerly known as JCO for those of you that have been in healthcare for a while. So this involves a peer review process in which survey teams evaluate healthcare institutions to evaluate their compliance with established minimum standards. These are minimum standards. Now what's important to note is that from a nutrition standpoint, one of those minimum standards is that nutrition screening must be done within 24 hours of admission. Now remember, that is screening, not assessment. Screening, which is this patient at risk? Do we need to see them more? And we'll talk about that, right? So assessments happen 48 hours, within 48 hours after screening. Screening happens within 24 hours of admission. You must have a process improvement plan, so in case you detect things go wrong. And if you're really curious about the Joint Commission process, you can go to their website to learn more. So again, what do these focus on? Which is care of the patient standards, which is kind of where nutrition gets involved, which is timely and effective nutrition care, your screening, assessing, and reassessment processes, development of a nutrition care process. So how do you do this? Is this a computer system? Do you have a form, etc.? The ordering and communicating of the diet order, so between the medical professionals and the kitchen. Preparing and distributing of the diet order, so meal tray delivery, and monitoring the process with continuous quality improvement. So fix your mistakes. So RDs are actively involved in the survey process. Now again, we've talked about Joint Commission, but there's also state and local government and licensing agencies. So in Florida, we have ACA, which is the Agency for Healthcare Administration for our long-term care facilities. And we have DCF, which also can take a look at elder care services. Now, one of the other big things that they're monitored for is sentinel events. So this is an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. And so these outcomes must be documented in the medical chart, and this warrants an immediate investigation and response. So let's take a little bit of a look at the documentation of the nutrition care process. So we have our medical record, and this serves as a tool for communication between different members of the healthcare team. Now in 2014, healthcare facilities were supposed to transition to electronic health records to document patient care, store and manage laboratory results, communicate with other entities, and maintain all information related to an individual's health. Now everyone has switched to at least some components being electronic, but I can tell you that certain places, facilities, dietitians' notes or other services notes may still be handwritten. So I actually still paper chart at one of the facilities that I PRN at. So the documentation in the medical record, again, is a systematic recording of the patient's care. And again, it's written in this tone. It's an ongoing conversation between different members of the healthcare team to create a consensus. So a clear, concise, comprehensive record of the patient's treatment allows for continuous quality improvement, so we can go back and see what we did, what went right, what went wrong. Uses terminology and coding consistent with a prospective payment system to facilitate reimbursement, which is why we have to use specific language and words and diagnostic codes. And again, these are legal documents, so this can be requested. This can be used in lawsuits, This can be used in government agencies, etc. Do review these documents. Now again, looking at the organization of nutrition documentation, so dietitians used to use SOAP notes, but other healthcare practitioners still do. So for example, physicians may still write in a SOAP note format. So again, this is a very well-known format. So you have subjective data, and your subjective data is basically your not numbers, which is patient states, patient feels, patient appears. Then your objective data, these are the lab results, this is the blood, this is the toxicology, this is the urinalysis. Assessment, which is what does it all mean, and then the plan. And then the ADIME, kind of what we really did is we still have that same information. So subjective and objective data is all part of assessment. We've added a diagnosis. We have our intervention, which is our plan. And then our monitor and evaluate used to be in plan, but now again, it's that separate, what are we going to follow up on component. Now, if you are using paper, and like I said, some facilities still are, especially long-term care, it needs to be written in a black pen or typewritten, so no blue ink, clear, concise, accurate, and legible. You always need to have a date and time. Each page should include the patient's name and hospital ID number. It needs to go in chronological order consecutively. It needs to be consistent and non-contradictory. So that means we don't put recommend tube feeding, doctor not ordering tube feeding, doctor is an idiot, Do not put things like that in the medical record. And do not leave white space or blank lines, as it looks like you could go back and alter the record at a different time. The first word of every statement should be capitalized with periods at the end of each thought. So this isn't complete sentences, this isn't writing essays, but we need to have some kind of order and structure. You write patient or client instead of the patient's name. It makes it much easier if files ever need to be edited. Sign at the end with credentials. And so the student, you'll write supervised practice student, and then it will also be signed and followed up with by your preceptor. Never chart or sign or pretend to be another individual. So if somebody calls you up, oh, I forgot to put this in the chart, can you write it for me? If you want to put your own name, that's fine, but you can't put somebody else's name. And avoid personal opinions and comments criticizing or casting doubt on the professionalism of others. So again, the documentation needs to occur at the actual procedure or occurrence. Although if there are late entries, you can identify them as such. So for example, some people do chart later. When correcting an error, you do a single strike through. You put your initials and write error, similar to the way you would use a lab notebook in a traditional lab setting. You never use whiteout, correction tape, or a black marker to try and strike through something. Never remove an original and replace it with a copy. Again, this is very suspicious. And if you do run out of room because of poor planning, you can use C addendum, and then you can add additional information with that addendum. Now again, we said that everybody was supposed to have switched to an electronic health record. Technically, you have electronic medical records, electronic health records, and personal health records, and these are different subsets of data. But for us, it doesn't really matter, It's all electronic, or we're hoping it to all move to electronic. And again, our notes will be incorporated into the right particular subfile. So federal requirements mandate that provider systems be interoperable, meaning that information can be safely and securely exchanged between providers and facilities. So while they do occur, you'll notice that MACs are much less frequent in their use in hospital settings because, again, it's all this proprietary software and encryption to make sure that medical records can be transmitted, without any violation of patient privacy. Now, when it comes to the medical record, at the end of the day, there's only one major rule, which is if it's not documented, it didn't happen. You can be the best dietitian in the world, but if it's not written down, it never happened. So again, following all of those rules, we have to actually chart what we did. Now looking at some influences on nutrition and healthcare, so we do have the Health Insurance Portability and Accountability Act, or HIPAA. So this was passed in 1996 by Congress, and this requires that healthcare providers and facilities have to safeguard any protected health information. And so a major goal of the privacy rule is to assure that individuals' health information is properly protected while allowing the flow of health information needed to provide and promote high-quality healthcare and to promote the public's health and well-being. And so the big concern, right, was in this digital world, especially, right, and that's why you'll see this in 1996, is that people's information could become too public too easily. And so again, this is really protecting that, right? So insurance companies can't, quote unquote, get a hold of your medical records and make decisions about you. People that you didn't give permission to shouldn't be able to view your records, etc. So RDs must use common sense. So don't look at medical records unless you're involved in that patient's care. Every time a celebrity goes to the hospital, somewhere between 10 to 20 people get fired because they just can't help themselves. Look, any computer at any hospital you use has a keystroke logger. When you log in, everything you do can be reviewed. So if you go into a patient's chart, they can see that. Now, of course, we've clicked on the wrong charts, etc., because there's thousands of patients here and you're just clicking. But they can also see that if you go, oh, wrong chart, and you just switch patient charts, right? You only look at the face sheet. They understand that kind of stuff happens. But again, everything you do is being recorded. So violations of HIPAA result in both large fines and termination from the position. And a legal suit can be brought against a dietitian who has disclosed information about their patients or clients without their consent. So if you don't follow hospital policy and you leak information, then a suit can be brought against you as an individual. Now we also have the Patient Protection and Affordable Care Act. So you might be familiar with quote-unquote Obamacare. And so the goal is for all Americans to have access to quality, affordable health care. And so these are regulations that require group health plans and health insurance issuers to provide coverage of dependent children younger than 26 years of age, and uninsured and small businesses to be offered affordable health care plans. So taking a look at our payment systems, so we have cost-based reimbursement, negotiated bids, and diagnostic-related groups. And so diagnostic-related groups are kind of the ones might be a little bit new. So here a facility receives payment for a patient's admission based on the principal diagnosis, the secondary diagnosis, surgical procedure, and age and gender. And so what you've done is basically you take an actuary's math and what you're looking into, so how long and how much money is it really going to take to treat this specific patient on average, and then we kind of have this negotiated price. Now we also have, so for example, you've seen with your insurance, you have PPOs, your preferred provider organizations, or your MCOs, your managed care organizations. So again, your PPO, you can choose who you want, and your MCO, so it has a contracted network of providers, which receive a monthly premium rather than a fee for service, which is, I live in Orlando, there's 500,000 people, based on my location, I'm going to see 5,000 of those. In a year, I'm going to see this many, so I'm going to be paid this much by this insurance company. Sometimes I get ahead and I make more money. Sometimes I'm losing money because I'm working hard. But right, it's supposed to all come out even in the end. So looking at why we would see patients, we have our nutrition consults. So there's a lot of different reasons you could be requested to see a patient. These could be things like weight loss, pressure ulcers, poor intake, being overweight or obese, weight gain, altered labs, low hemoglobin hematocrit, low albumin, diet education, diabetes, tube feeds, dehydration, fluid balance issues, dysphagia, GERD, constipation, and the list goes on and on. But looking at our interventions, right, so the RD is the licensed provider who can reliably offer food and nutrition services that are credible and highly individualized. So again, we're the expert and we're able to inform, educate, and inspire our clients. And again, our guidance is health enhancing and life changing. Hopefully we're doing great jobs. And so balance, judgment, and critical thinking is needed, right, to make these interventions. Now you will write for a patient a nutrition prescription, and this includes the type, amount, and frequency of nutrition based on their disease process and disease management goals, again being based on evidence-based practice guidelines. So we may specify a calorie level, limit or increase a specific nutrient. Maybe they need more protein, they need less fat, they need less carbs. And again, the prescription is always written after the diagnosis because, again, the prescription should be addressing the diagnostic issue. And this should not be confused with the diet order, which is simply what they're getting in the hospital. But we're much more precise than, a quote-unquote heart-healthy diet, right? Dietitians' orders are much more precise than that. Now, it gets a little tricky, so only licensed independent providers can enter diet orders into a patient's medical record. And so this is actually technically changed. So initially it used to be physicians, PAs, and ARMPs could write diet orders. Dietitians now can, but most facilities won't let them. Now, some facilities will let them, and they'll give you order writing privileges. So CMS has said we're okay if you do, but then each state and each facility can set up the strictness of their guidelines, but that's the bare minimum they can be. So usually we're not really able to write diet orders on our own. We write our prescription, and then we contact the physician or the primary on the case, and then try and explain to them what we want to change the diet order to. Most of the time, though, if you're downgrading a diet, which is you're making it more restricted, practitioners are okay. It's if you want to give somebody a less restrictive diet that there's some concern. So a therapeutic or modified diet starts with our generally adequate diet, and then this has been altered for an individual's requirements. So you start with the normal, regular food, and then we look at, does it need to be modified for digestive or absorptive capacity, alleviation or arrest of a specific disease process? Do we need to modify it for psychosocial, religious, or cultural reasons, personal preferences and eating patterns, and of course any allergies or intolerances? And so our goal is for the diet to provide the needed nutrients to the body in a form that it can handle. So again, we want to maximize digestion, absorption, and of course improve nutrition status. So alteration, or the way we change a diet, can be consistency, its energy content, its type or nutrient, so again higher in protein, higher in fat, lower in carb, etc. Elimination of specific foods, adjustment of the level, ratio, or balance of these macros, rearrangement in the number and frequency of meals, so we're going to eat less often, more often, and changing the route of delivery, so we're going to use a tube feed, are we going to eat orally, are we going to use IV nutrition, etc. Now what you'll see is that all hospitals have what's known as a house, regular, or general diet, which is just feed them food. So this has no restrictions or limitations. Again, it still has to meet at least the DRIs, so it's written and approved by an RD, but again, we just have to have enough protein, enough micronutrients, but otherwise it's pretty open to whatever the patient would like to consume. Now there are regulations though that govern timing, frequency, and the content. So you have to offer people meals at a certain frequency, so they can't go more than 14 hours without being offered food. They can choose to refuse it, but you have to always offer. Now a regular diet is usually somewhere between 16 to 2200 calories, 60 to 80 grams of protein, 80 to 100 grams of fat, and 180 to 300 grams of carbs. And so what you do is you look at your population. So let's see, I own a hospital, or I'm in charge of the food service in Naples. So we've got a lot of retirees. I do a review of my patient population. 90% of my patients are aged 65 and older, mixture of males and females, etc., etc. So then what I do is my house diet's going to be, what is the RDA for calories, or the AMDR? Well, the AMDR and the DRI for calories for people over the age of 65. What about their calcium content? What about their iron content, right? And so what I do is I create this general diet that's going to basically, it's going to meet the needs of who actually comes to this hospital. Now we can always do consistency modifications, which is really not that difficult. So this is needed for patients with chewing or swallowing difficulty. This is things like pureeing, mechanical soft, ground or chopped meats, thickened liquids. Your regular diet always starts with thin liquids, and then we modify from there. But pretty much any food you can think of, we can modify to meet these standards. Now you may see a clear liquid diet, and I'll give you a hint. This includes all foods that are clear. Jello, juice, broths, popsicles, tea. If you can see through it, it makes the cut. Things that are full of fiber and pulp, though, like orange juice, don't make the cut. This requires minimal digestion. This is used in times of GI distress or a prep for GI testing. It's often used after surgery to help transition to a regular diet. Although that's just based on expert opinion, there's not actually data to suggest that it's an improvement into just eating regular food. And there's actually been a call to actually just have patients advance to regular food after surgery. So we'll see how that changes. The problem is a clear liquid diet does not have enough calories, protein, vitamins, or minerals for any long-term consumption. On average, it only contains 500 to 600 calories with 5 to 10 grams of protein, minimal fat, and 120 to 130 grams of carbohydrate. And patients will probably need additional IV fluids until they're advanced to a more nutritionally adequate diet, just to get enough total volume and enough fluid. Now we also have to consider the osmolality, which is this high sugar diet can cause GI upset and may be poorly tolerated. Now a full liquid diet is things that are still liquid or would be liquid at room temperature, but are not able to be seen through. So this is going to be dairy, ice cream, supplements like Ensure, yogurt, cream-based soups, etc. It does contain a fairly large amount of lactose, so again, this can actually cause GI upset, but this can better meet nutritional needs than a clear liquid diet, but still not recommended for long periods of time. Now, it's important to remember that food served does not represent actual intake. So again, just because you sent it to a patient's room doesn't mean they actually ate it. And on the flip side, if they're ordered a supplement, that may be additional nutrients. They may be drinking the supplement instead of eating. They may be getting food from outside brought in by friends and family members, so they're still getting adequate nourishment, just not from the tray. The patient may obtain food from the cafeteria or vending machines. Again, not that they're always supposed to, but things happen. So again, we want good communication. Again, this is where the techs and nurses are your friends, because they're going to often see like, oh, I just saw him, with a Chick-fil-A bag. His family brought him Chick-fil-A because he was craving a fried chicken sandwich. Okay, the patient's still getting plenty of calories, right? So again, our goal is to make sure they're getting nutrition, but if we can modify, right, what we're serving them in the hospital to better meet those needs, that's ideal. But at the end of the day, I just need to get them fed and nourished. Now, calorie counts is where we actually track closely what you eat for 3 days, may be needed or used to justify the need for a tube feed or IV feeds. So looking at acceptance and psychological factors, so meals and snacks are the highlight of the day. Again, the biggest thing is that food is one of the few things patients can control when they're in the hospital. You wake up when they come to bug you. You answer the doctor's questions. You go to the bathroom when they come to help you. Like, everything kind of sucks when you're in the hospital. But food stays pretty normal. So again, this is the highlight of the day. I get to eat normal food. It usually tastes pretty okay. Like, I get to be left alone for a little bit. Give me 30 minutes to eat my food. Like, it's the highlight of the day. We want this to be a positive experience, a comfortable setting and position. So we want to make sure that people are sitting up in bed, or if they're at a table, if they're in long-term care, making sure that they go to the dining room. We know that eating with others can promote better intake. So again, this is especially important in long-term care. Arrangement of the tray should be appealing and convenient. So again, this is also a mixture of temperature control. Feeding assistance may be required. Again, this is usually looking at long-term care or acute care, things like strokes, etc. And again, this is just a given, but personal selection of menus always improves acceptance. Even if you only have 2 choices, giving people the choice improves intake. Now, you're seeing right now is that room service, which is you call and tell people what you want, is very popular. It does get better acceptance and people like it more, but it's a whole lot more expensive and time intensive, because you have to make sure that everybody's getting what they want, getting it delivered when it's hot, they receive it in the order it was ordered. It creates a lot of logistical issues that you have to plan for. Looking at supplements, so we have our medical food supplements. So these are used to increase nutrient intake when the patient is unable to meet their needs through diet alone. And so these are beverages that are somewhere between 240 to 360 calories per 8 ounces, which is 237 mils technically, just say 240. Somewhere between 7 to 15, even 20 grams of protein these days. And ideally, we'd like to see them between meals to, again, supplement, not replace, supplement food intake. The type ordered, though, depends on the patient's needs, their medical condition. They're not technically lactose-free, but they're low enough in lactose that they can be tolerated by patients that require a lactose-free diet. Examples include things like Boost, Ensure, Ensure Plus, Ensure Boost High Protein, Glucerna, Mighty Shakes, Carnation Instant Breakfast, Resource Health Shakes, MedPass, etc. Now, with the issues of low protein in clear liquid diets, you've actually seen a new category of product. These are our clear products like Boost Breeze, Ensure Clear, and Enlive. Now here we have some other strategies to increase nutrient density. So supplements are great, but we'd always prefer a food-first approach. So I'm happy to use supplements, and especially if patients are like, oh, I just love to have a chocolate Ensure after dinner, it's just kind of my thing. I'm like, okay, that's fine. I'm more than happy to order that for you. But we don't want to get lazy and just go, just give them an Ensure, right? We can increase calories with food. So for example, butter. We can put butter on everything. You got bread, double butter. And if you think vegetables taste good, wait till I melt some butter over those peas. We can add extra jam and jelly. We can use whole milk instead of low-fat milk in vegetables, so creamed vegetables, soups, casseroles, etc. Adding sour cream or yogurt again. Nut butters or cream cheese to again increase intake with snacks. If we want to increase protein, we can use things like powdered milk or liquid eggs. We can add things like nuts, nut butters, chopped meats, cooked eggs, cheese, or yogurt. So again, broccoli is good. Broccoli and cheese is even better. Extra calories, extra protein. Again, we can also add tofu or soy crumbles to prepared vegetables, soups, casseroles, etc. Other supplements or additives that we can provide patients. So we can add polykos, which is a form of glucose modular. We can add ProMod, ProSource, or ProStat, which are hydrolyzed and highly absorbable protein liquid modulars. We can also use protein powders. MCT oils, Magic Cup, which is a special type of, in essence, an ice cream that doesn't melt. It's kind of cool. It's some cool food science. Ensure and Boost pudding, so they also come in a pudding form. And we can also use fortified foods. We also have adaptive equipment. So again, we talked about that feeding assistance. But again, if patients, we'd like them to maintain their independence as long as possible. So we can have special equipment that can help. This includes built-up utensils with thicker grips to make it easier to hold, divided plates, plate guards, or lip plates. So again, you can basically, if you ever tried to eat peas, you can now literally pin them in the corner because you've got a plate guard. Patients, though, may need assistance with tray setup, minimal assistance, right, which is just your queuing and your setting up. Hey, don't forget to try this. Extensive assistance, right, which is helping them, with a few bites and there's technically a guideline for it on the time. And then total assist, right, where you have to actually feed the patient every single bite, which again requires a one-on-one interaction. And there's actually some rules about that, and we'll talk more about that with long-term care. Looking at medication management, so certain medications need to be coordinated with meal times. For example, pancreatic enzymes have to be taken with meals. And for example, anti-nausea medications like Zofran actually need to be given 30 minutes prior to the meal for maximum efficacy, so to make sure they work as good as possible. We have to be concerned about drug-nutrient interactions, which we talked a little bit about. Side effects of medications includes, for example, things like steroids, which increase appetite, change blood pressure, and blood glucose regulation. We may also use things like appetite stimulants like Megase or Dronabinol. So again, medications can be good, bad, neutral. We just need to make sure that we take them into account when treating our patients. So looking at nutrition education, so again, this is instruction or training in a skill or knowledge. So the goal is to assist with the control of disease or symptoms, improve health status, enhance the quality of life, and help decrease healthcare costs. When you're doing an education with a patient, you need to communicate the purpose of the education. You need to tailor the education to fit the individual patient's understanding, their level of baseline knowledge, their skill level, and their learning style. So again, maybe they need handouts. Maybe they need to be shown something hands-on. Group classes, individual instruction, written instructions, and phone or electronic communication are all allowed and viable methods. But again, make sure you're using something that's appropriate with your patient. Again, you're probably not going to Zoom with your 85-year-old patient. You could. Again, this is why we check and treat them like individuals. But on average, probably not the focus. Now, the outpatient setting is more conducive. So the inpatient setting, you're really focused on basic counseling or survival skills. So for example, with diabetes, our focus is on checking your blood glucose. If it's too high, what do you do? Right? Or if your blood sugar is too low, what do you do? The whole, how do you feel about foods and how do we switch you to more high fiber foods and reducing our carb intake for the next 6 months, that's more outpatient. Now, counseling is very similar to education, but here instead, so we're looking at behavior change. So education is truly knowledge, which is I just didn't know any better. Counseling is so what are you going to do about it? How do you actually change those behaviors? So effective counseling is greatly influenced by the relationship you build with the client. The ultimate goal, though, is that they're going to evoke a behavior change that they can become self-sustaining. So I'm going to teach you the skills to change your behavior, and you're going to keep doing it. Now, we do have follow-up counseling sessions. Again, this is going to reinforce the basic counseling. So you may see somebody intensively for the first 6 weeks, And then I'm really just going to check on you once every 6 months. If you're still doing good, you don't need me, right? When you're counseling, your goal is really to put yourself out of a job, right? Which is never going to happen with our current health crisis. But the idea is that they develop skills to help themselves independently, not use you as a crutch for the rest of their lives. So here's some of the characteristics of counselors that promote a positive relationship, and we'll go over more of this in the actual counseling class. This is just the very intro. So this is behaving naturally and being authentic, having a sense of humor, being flexible, being optimistic and hopeful. Can't be a Debbie Downer and be a counselor. Letting the clients actually do the talking. You're really just encouraging them to kind of reach their own conclusions. Appropriate eye contact and body language. And again, this is very culturally dependent, which we've talked a little bit about, is my understanding, but I'm happy to go through more of that with you all. So again, you have to be able to understand what's appropriate for that culture and what's making the patient comfortable or uncomfortable, and listening with an open mind and a spirit of inquiry, which again is, we're just kind of exploring this process, how people change their own behavior, right? I'm not here to be the food police or tell people what to do. And here's an example of some effective communication skills, and so you'll have entire chapters on this in the counseling class. But for example, a clarifying or probing question, tell me more about the classic paraphrasing. It sounds like you're telling me, right? We've got our empathy, we've got our conveying respect, which is you've done a great job with this, right? And so this is how we get them to, again, continue to talk, explore their feelings about food, right? Explore their behaviors about their health, etc. Now here's examples of some of the theories. I just want you to know that multiple theories exist. That's it. The actual specific theories and who came up with them, this is fair game for the RD exam, but we will go over this in the counseling class. So for example, person-centered counseling's Carl Rogers, social learning's Bandura. Like, that is fair game for the exam. You do not need to know it for MNT. You will need to know it for counseling. I just want you to know that all of these theories exist, and you as a dietitian are allowed to use these when changing nutrition behaviors with your patients. So looking at a coordination of care for our interventions, remembering that we work with lots of other healthcare professionals, and so we're focused on a successful transition from the healthcare facility to the patient's home or other facility. Right, I want to set you up to be successful when you leave, not just while you're in the hospital under my care. So we do have team meetings or care plan meetings where we discuss patients and how their care is going. And again, referrals to community agencies. Are they going to see a specialist? Are they going to see a dietitian ongoing? Are they going to come for some outpatient counseling and training, etc.? Now, discharge planning does include nutrition care. And so nutrition discharge summary is important for the next caregiver and should include a summary of what you did and the outcomes, pertinent information like weights, labs, and intake, any drug-nutrient interactions that you were worried about or observed, expected prognosis, amount and type of instruction given, the patient's comprehension, expected degree of adherence, and recommendation for follow-up service, so that when I go from acute care to the long-term care facility, the dietitian can hit the ground running and go, oh, I saw that so-and-so at the hospital talked to you about this. And they go, yeah, we talked about this. And they go, well, I wanted to talk to you a little bit about more and look at our menu here so you can keep working on that skill, making those food choices. Here's our menu. Let's talk a little bit more about carb counting, as opposed to, have you heard about diabetes? And they're like, yeah, the dude at the hospital talked to me for an hour about it, and you just told me the same thing again. Now we'll also talk about nutrition for the terminally ill or hospice patient. So our goal is a maintenance of comfort and quality of life, and so nutrition care should be mindful of strategies that can facilitate symptom and pain control. So it's a very touchy subject, but again, realizing that some of this is physiological, some of this is cultural. Most often, dietary restrictions are rarely appropriate, but again, response to food nutrition support can be different depending on where that patient is at their end of life stage. So again, they can be in denial, they can be very angry, and they'll take it out on you. Again, this is our bargaining, depression, acceptance. This is if that patient's going to participate in aggressive therapies. Are they refusing all treatment options? Again, are they using some restrictions? And just realize it's nothing personal. It's not about you, right? It's really just the patient and what they need to feel most comfortable, whether that be physiological, psychological, etc. Now, what we do want to make sure that we always check for is advanced directives. So this allows the patient to advise family and healthcare team of individual preferences regarding end-of-life issues. And these become activated once a patient has a certificate of terminal illness. But if there's no advance directives or living will, and the patient is incapacitated, then the decision resides with the family, and there's technically a hierarchy with spouse, oldest child, etc., etc. But I can tell you, and you would think, oh, well, somebody else is going to do this. I actually have a former student, now colleague, who they were about to place a PEG tube in a patient, and nobody had thought to check for advance directives. And she just happened to be conversing with the family and asking, like, oh, did he ever say anything about this? And they go, oh, well, he has these advance directives. Sure enough, there was a signed legal document that said, do not give me a feeding tube. And the doctor was about to put a feeding tube in the patient. The dietitian literally had to run after them and be like, no, 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 no. You cannot do this. This patient has said they do not want this, right? And again, it's not up for you to decide personally if you like it or don't like it. It's whatever the patient wants, that's what we're going to go with. And so she had to literally stop the doctor and be like, if you do this, we will get sued. Like, you cannot be poking holes in this patient. So again, you'd think that's something that we're not really involved with, but we are. Patients may have comfort foods or feedings only where, again, it is natural for the human animal at end of life. They will have severely decreased food and fluid intake, and that's very normal. But we'll still provide patients with comfort feeds, which is, I know you're not meeting your nutrition needs, but instead, I'm really just providing food for if you've got dry mouth, if you just want something to sip on, if you just want a little soup. We're going to continue to give you food and nutrition, but I know you're not meeting your needs. It's really just letting you figure out what's going on with your body and whatever you're comfortable with. Now with palliative care, right, so our goal is to alleviate the physical symptoms, anxiety, fear, etc., while maintaining a patient's ability to function independently, but we're not actually treating anything, right? Palliative care is just treating the symptoms, not the actual problem, because there just may not be an available treatment or a functional treatment that works. There's also hospice home care. You can also do it at a facility, but this allows a terminally ill patient to stay home or go through, again, it's still a medical facility, but it's less medically, if that makes sense, where again, they have a different goal, which is treating, right, for comfort, reducing anxiety, right? We're not here to poke holes in you and try and treat you and do these drastic measures. It's just a very different setting and focus. Now, according to the Journal of the Academy of Nutrition and Dietetics, we do have a position, so for ethical and legal issues in feeding and hydration. So we've said that individuals have the right to request or refuse nutrition and hydration as medical treatment. And this is not just end of life, this is at all times. You can just say, no, I don't want that. RD should work collaboratively as part of the interdisciplinary team to make recommendations on providing, withdrawing, or withholding nutrition and hydration. And RDs have a responsibility to promote the use of advance directives, as my former student, now colleague, did. So again, things you didn't always realize you'd have to do as a dietitian, you may be called upon to act. All right, so let's take a look at some review questions. So what is HIPAA? And so that is answer choice A, ensures privacy and security of personal information in the healthcare setting. Number 2, the final step of the nutrition care process is, and that is also answer choice A, monitoring and evaluation. Number 3, the most important person in the nutrition care process is, and that is answer choice D, that is the patient. I know, we're super important and we help with a lot of things, but remember, the patient can refuse or accept any treatment. So we need that client buy-in, and we need them to actually want to participate in this nutrition therapy, because again, they can accept or refuse any therapy. They're going to make the choices, they're going to choose to eat, so we really need them to buy in. Number 4, the focus of nutrition care for palliative care. And that is answer choice A, the maintenance of comfort and quality of life. So again, I'm not really treating anything, I'm just reducing anxiety, improving comfort, maintaining functional status as long as possible. I thank you for your time, and I look forward to your questions.